Hello everybody. Today's presentation is the office setup for the surgical implant practice. So I'm going to take you through some of those specific terms and specific concepts which we like to do today when we go into the office. And as you can see here, implant dentistry has evolved over the last decades. And many of you who are listening to this program and are going to be looking at implant dentistry are probably in at a very good time, because what's happening is that we're dealing here with implant dentistry which now goes for about 40 years in our programs and in our practices. In the mainstream of dentistry, it probably is about 20 years. So there's 20 plus years of experience with implant dentistry, but still implant dentistry is, when we look at the practices around the world, is still a very small penetration when you think about the consumers and the patients out there who could benefit from this type of modality or therapy. We're talking at about a penetration into the market somewhere between a few percent up to maybe 12%, depending on the market we're talking about. Maybe major cosmopolitan areas, 5 to 10%, and some countries around the world where it's even higher, like Switzerland, because of the higher standard of healthcare. So for all those of you who are interested and now are moving into the field of implant dentistry also to place implants in your own dental practice, this presentation will be good for you to see what we do in our surgical practice, which is an exclusive practice for implant placement and for tissue management. And so I'll share with you some of these things which we do on a daily basis. Now first, it is important to say that the survival of implant is something which we much more today feel already to be secure about. I mean, we feel very good about the new implant modalities, the implant designs and surfaces, that they can secure success rate. What we are very much interested in today is to develop a certain type of quality which is up to the high standards of today's practices, of aesthetics, as well as of comprehensive dentistry. So today, when you look at implant dentistry, it's going to be much more the quality of the implant survival, which is going to be interesting for you, and it's going to be very interesting for your patient, because this will be something which really will be conducive to the same way you're trying to practice today and deliver success rates as well as enhance your practice. So we're going to be looking at, when we develop these implant office concepts for surgery, also at really improving the quality of survival. Of course, what happens is that we're very much today looking at implant dentistry, and here I'm going to give you an example. This is a beautiful smile line which was created with a team which I was involved with in Italy, and the patient had an anterior trauma which fractured some of the anterior front teeth, and then after implant placement and after full ceramic restorations in the anterior maxilla, you can see here a very nice final result for this particular patient. Of course, the question is, how long is this quality which we have delivered to this patient going to survive? And here you can see how in this particular case the result is attainable for 5+ years, and obviously this patient is still enjoying this type of restoration and this type of result. So you can see here how this particular patient was able to have not only a survival of the implants, but also have a success with the restoration. The particular case here, you can see the surgical treatment, and the surgical treatment here showcases that 2 teeth were lost and had to be extracted. Immediate extractions were placed, and the immediate extractions here meant that one side, the lateral incisor, received an immediate implant into an extraction site without a flap, and the central incisor received an implant where we can see this here being positioned with a flap and needing a bone graft to enhance the site. This, of course, is the clinical execution. What we often then do, of course, is manage these tissues in the concepts which we have today. The other question, which of course I want to answer today with you, is what happens on the background when you're looking at how do we organize our office, and how do we organize the office when you're looking at the restorative team. Now, this particular patient, which you're looking at right now, was treated in the dental office of Dr. Mauro Fradiani in Italy. So this was a restorative office where mainly prosthodontics and aesthetic dentistry was being delivered to the patients. So I came in here on a consultation basis, and we pretty much used the concepts which we have today in our surgical field, and we just transferred like one of the dental offices into a small surgical suite by using hygienic as well as strict guidelines, which I'm going to discuss with you. So there's no need today, when you're looking at implant dentistry, to really think that a dental office cannot be turned into also one of them into a surgical suite to do some surgical procedures. And this was one of these things where we did this. So now, before we go into the surgical organization in your office, let's look at some of the aspects which are important from a generic standpoint on how to pick a patient. First of all, when we do surgical procedures, we need to always define the type of patient which we're going to be treating. And you can see here, is the patient we're going to be looking for, is it a patient who is only missing teeth, or is there actually missing soft tissue and bone tissue and teeth? This will be slightly different because, of course, the surgical clinician will have to bring into this concept the augmentation which comes with this particular type of procedure. The second step, of course, is the aesthetic versus non-aesthetic reconstruction. And this is important for the surgical clinician because you're dealing here with precision. And when you're dealing with aesthetic treatments, you usually will have to have a precision which really goes into tenths of the millimeters. So a surgical guide stand is very important to help you. A diagnostic wax-up, as you'll see, is very important. And this all brings with it a certain amount of precision. For the surgical clinician who is still developing and is not as experienced, a non-aesthetic implant placement is easier and is simplified due to the fact that we don't need to really go into these high precision placements, and restoratively we can manage cases very well, even if the implant is just maybe a millimeter more distally placed or more mesially placed. Next, choice of patient. You're looking at often patients which you're selecting for fixed versus removable. Again, any kind of fixed restoration in an edentulous arch is going to be more difficult from a surgical standpoint than a case where you're going to do removable. And it purely has to do with the implant placement. So if you have to select patients for your overall treatment and for surgical placement, I would recommend that you go with a removable treatment plan for these cases, because it will be easier for you to do. And it will be easier to satisfy a success rate for your patients. Fixed is something where, again, often grafting comes into play, and often you need a high precision in implant placement. Next, a point of differentiation, you want to look at the occlusal aspects, and this, of course, you're very much known to because of the types of patients you have in your restorative practice. Bruxas are usually relative contraindications. Teeth which have dropped down from an antagonistic position are contraindications, so you want to be looking at this very carefully. And the next is immediate function. Most likely, it is an easier treatment to do and more successful for the still unexperienced surgical clinician to place implants and do an immediate function concept, just because of the high precision needed in these kind of cases. So my recommendation would always be to do an one-stage implant or even a submerged implant placement to be slightly more conservative, and then once the experience of about 10 cases has developed, then you can go to more an immediate function concept. All cases, of course, have to really have optimal oral hygiene. So this is your list of patients. Now the next thing you're going to look at is really when you're looking at surgical placement and these kind of patient treatments, it's really what is the quality of the bone. And there's a certain amount of expectations which you can look at, but overall you just want to classify patients and their jawbone positions into these different types. And you can see here, type 4 bone, obviously what we call today soft bone, and having an opportunity, of course, for implants not to have the optimal stability. So type 4 quality bone, mainly diagnosed in the posterior maxilla, needs specific implant placement guidelines, and also probably the best type of implant to place in these areas is a tapered implant. Dense bone, also an excellent indication for implant stability, because you can place an implant and have optimal stability. But at the same time, it has a side effect which obviously you need to look at, and that is that very dense bone, of course, makes it more difficult to drill into. It makes it more difficult to place an implant, and at the same time, of course, it makes it also a bigger problem for potentially having an overloaded situation. So you're looking here at potentially treating these kind of cases and then having a potential for over compressing the bone. So if you have the choice, your ideal cases for implant placement is quality 2 and quality 3. And those happen pretty much in the anterior maxilla, in most of the mandible, and parts, of course, also of the maxilla. So bone is important depending on experience of the clinician, and I would try to focus more on the quality 2 and 3. Now, how do you diagnose this here? Now that you know what your quality is, not so easy. It's very subjective. So what we're doing today, we're diagnosing bone often by a CT scan. We're diagnosing bone also once we start the drilling procedure into this jawbone site, and then we can just feel by the resistance that the drill has how much of this resistance is being enjoyed by the drill, and then of course you can dictate yourself into the types of bone quality. So this here gives you a good feeling for where you are. Now the next step, of course, is to discuss where do you really place the implant. And this probably is an area which I would recommend any clinician starting with surgical implant dentistry to really consider this here, because what you're dealing with is that the less surprises you have, the better your end product will be, so the better your implant position will be. So you're dealing, for example, with treatment planning. This will give you the appropriate occlusal scheme, it will give you the appropriate emergence profile, and also the appropriate aesthetic outcome which you want to predict. How do you communicate this? Of course, the best part is through surgical guide templates. Now, when you work in a team of specialists, like I do, we need this here, because the other specialist is often in much remote locations in another part of the city, or even could be in the same building but is not available. But we need the communication. If you are the restorative dentist and the surgical dentist for your implant needs of your patient, of course it's a bit in your own hand. Still, your life as well as your result will be much improved if you deliver these surgical guide templates. So for me, any case where you're doing surgical procedures and placing implants benefits from the development of a surgical guide stand and then the placement of this during the procedure and then using this for implant placement. This then can allow you to position an implant really optimally, and as you can see, you can really choose the optimal mesiodistal, you can choose the optimal buccolingual, and you can choose the optimal apical position. So truly you can help yourself with these kind of templates. And also, if you develop a template which gives a good profile in the scan and you use some radio-opaque material in the template, you can actually also see the relationship of your implant placement with the anatomy. So this also can improve the overall status of these kind of cases. So here's a diagnostic wax-up of a patient which I did a few years ago, and you can actually very nicely see here how we have a treatment plan in this case. Study models were prepared, articulated. Now we can evaluate the distance from the crest of the posterior mandible to the opposing dentition. We can evaluate the curve. We can now also evaluate already in a really like simple fashion the width of the jaw. And if you would have a type of model-based analysis you do, you can just do by utilizing a ridge mapping, which means that you're going to measure the thickness of the soft tissue at particular points. You can already get kind of like a feeling for what the ridge dimensions are in these areas. The next step will be is that your technical team, so your laboratory team, will make a diagnostic wax-up, and this diagnostic wax-up then can be utilized, as you can see here, to make a radiographic as well as a surgical template. This surgical template then will allow you, as you can see, to have a very stable position on the adjacent teeth. It's made out of clear acrylic, and it has the full form of the tooth. So I want to have the full form contour of the tooth, so when the drill goes in, I can completely be able to determine where the position of this implant will be. The opening in the occlusal areas of these type of templates, I like to do with a minimum of a 3mm drill, and you can even go up to a 4mm drill because it will make it easier when you make a radiographic template to put the gutta percha in, and the gutta percha will nicely showcase the overall position of where your guide should be as well as where your implant is. So this gives you a nice way of controlling this. Here you can see it, a little summary. This is even a more critical one, because this particular case now is a surgical template done for a canine position, so it would definitely be an aesthetic position. And you can see how here my team member has done what I say, clear, hard acrylic stent, which is stable on the adjacent teeth. There's a full contour of the tooth visible. There's the gingival profile, which is visible. And the occlusal opening is more than 3mm. And I like to keep a buccal thickness of the stent of about 2mm. So this gives you a very nice way of demonstrating how you can work with these templates, and they can help you as well in the posterior mandibular case as well as in the anterior maxillary, a very aesthetically demanding area. So this is our first look at planning and setup. The next of course, is then to deliver the result, and that's what you can see here. This patient with a canine had then a final restoration made, and you can see the final restoration. This was done with a team member at UCLA, who then later moved to Zurich, Switzerland, Dr. Stefan Paul. And you can see here quite a nice follow-up of the pre-op diagnostics, the surgical template, the implant placement, and then here you can see the final restoration. So now, very few mistakes can be made. And it's better for you to control. So, I mean, I like this here because it gives me control in the case. Now, let's talk about implants and office setup. How do we really look at these type of cases, and how do we decide what implants we're going to use? First of all, you're going to be looking at a differentiation between two types of implant systems. One is what we call the parallel wall systems, and the second one is the tapered systems. So the most popular utilized implant for parallel wall is the Brånemark system. And I've used it for many, many years, and it's been extremely successful. The second system which we use today is the Replace Select Straight. The only difference between the Brånemark and the straight is the external versus internal connection. Now, I'm giving you here some specific implants also, which are Noble Biocare products. But if we stay more generic, we can just stay generic in the field of like being parallel wall and tapered systems. That will work for those of you who are listening right now and viewing right now if you don't use the Noble Biocare implant system. So the parallel wall system are very universally applicable. So if you want to use a parallel wall system in your office, pretty much any indication will work. And the only indication which I feel is not optimally served by a parallel wall system is soft bone, so the type 4 bone we talked about, and extraction sockets. So those are two which are not completely served by a parallel wall system. Can be done, but a little bit more difficult. Now let's move to the tapered systems. Tapered system came into, of course, a certain amount of demand because of the more natural form of it, like a root. So the most used system which I have in my practice is the Replace Select Tapered. And it has some subsystems, which you see here, the Noble Direct and Noble Perfect, which I'm not going to talk about right now because they are specific indications. But the Replace Select Tapered is a very universally applicable implant. Now, this implant has as an, I would say, number one indication, the extraction socket, because there it just fits perfectly. Then you can use it in any other indication, with maybe the only exception where you have to be very careful is dense bone. So it's the opposite of the parallel wall systems. And it's clear, because this is tapered, so it condenses the bone. So when you have very dense bone, you have a risk for over-torquing and over-pressuring the bone. You can prevent this by preparing the bone very carefully with your drills and preparing it in such a way that you have a tap, pre-tapping the bone site, so when the implants get seated, it's very passively moved into its site. Now, what system do you choose and what implant do you choose? Of course, I always have a plan A, and then there's a plan B. And plan A will be that I will maybe use a straight implant, which could be an 11.5 millimeter implant, regular platform, but then I still have an opportunity, if I can or if I need, to go maybe to 10 or to maybe go to 13. So I never open up the final package of the implant till I've really completely confirmed the position, the length of the drill, and the final site. So then we have decided that we're going to open this, and now we're going to go to the first movie. This will be the movie of the implants. Then, of course, we come into the organization of our office, and now we have a sterile assistant which will open up the package. This package is a non-sterile package, so this has to be opened by the staff member, and the staff member will open this here and drop it on the sterile surgical field. So let's look at this together.
The non-sterile assistant is now ready to open the individual implant package. Pull the red sterile seal tab. Unscrew the top and invert the container above the sterile field, carefully letting the implant drop onto the sterile field. Do not place the container on the sterile field as this packaging is not sterile. At the end of the surgery, we must take the label from the implant container and attach it to the patient's chart. This contains specification of the implant dimensions and the lot number. The other sticker on the implant container may be given to the referring dental office. The sterile implant sleeve can now be handled by the sterile assistant. Open the cap and pick up the implant with the implant driver mounted on the handpiece. The assistant should carefully carry the implant handpiece by placing one hand right underneath the implant to prevent the implant from dropping on the floor.
And this is a little joke. You can see you don't want this to happen. So this here, the final aspect of this video showed you that if you're not careful, these implants of course can fall out of their container, and then you have a very expensive implant product which just is on the floor and you will not be able to use. So by connecting the implant to the driver, you want to really make sure that the position is very, very secure. So we're moving forward and looking now at the next choice in your office. And that is really when you're looking at implants, what is your optimal diameter? And when you look at the evidence in the literature, and if I look in my own personal office, from an organizational standpoint, you most likely are going to be using most implants which are a regular platform in diameter. So one thing I don't do so much. I don't do what we call today utilizing the narrow platform implant. We don't do the narrow platform implant for narrow ridges in any other areas than where the narrow implant is really meant to be. So a narrow ridge, let's say a premolar area or molar area, we're not going to fit a narrow platform implant into. I still will maintain my position of using a regular platform implant, but I will use grafting procedures either simultaneously with implant placement or I'll use them prior to implant placement. The same, I will not really push a site with wide platform implant because it's not necessary. The regular platform implant is a very well universally researched implant in most implant systems, in most of the sites, and so it works really well. So we don't step down with the diameter if there's little bone width, neither do we step up if there's little bone width. So regular platform is a very good system, and we use like really just the wider or the narrow ones when indicated from a standpoint of more restorative needs. So of course narrow platform, a good example would be a lateral incisor. A wide platform, a good example would be the molar. The next one is the length, and this is an interesting point because you'll be able to see that of course all systems which are out there offer you a tremendous diversity in implant lengths, but in practice we're using predominantly between 10 to 13 millimeters. 10 to 13 millimeters. And the research is strong enough today to say that a 10 millimeter implant with a rough surface, for example, taenite, or an acid etch surface, or a sandblasted surface, or some of the more bioactive surfaces, will develop a very strong bone to implant anchorage, so we don't have to worry about it. So I'm not really nervous about staying within that range. Sometimes I'll use longer if I can't get stability, and sometimes I'll go shorter, but those are really more specific indications. So if you have in your office a good number of implant stock, which is a regular platform and ranges from 10 to 13, you really will have a good selection for your implant care. And then you add whatever is necessary. The next step, of course, is then to choose what implant system really to go for. And probably today, I would say preferred by most colleagues would be definitely an implant surface, which first of all is rough, so which is enhanced. So that's probably your first choice when you're looking at implants. And in the Noble system, it would be the taenite. The second system you have to look at is really, what do I choose, parallel or tapered? And if you have the opportunity, obviously both are a good indication, parallel and tapered, because as I mentioned earlier, they both have a little bit of their relative risk. Tapered for over-compressing the bone when it's very dense, and parallel, that's difficult to place them in sockets, and in soft bone, again, they lose stability. So you have a play around. Now, if you have to choose one implant, I probably would go with the tapered, and that's what I would recommend, the Replace Select Tapered, and then you have them, as you can see here, on the left-hand side, which very well fit into regular jawbone and very well also are able to be placed in extraction sockets. Now, more specific implants like a parallel walled implant and a short implant, like this is a shorty, which is only 6.5 millimeter in length. These are implants which really, I believe, you have to have a little bit more experience with implants, because you have so little length to work with. So the shorty implant is a potential implant indication for the posterior maxilla as an alternative option to a sinus lift, and to the posterior mandible if there's an insufficient amount of bone there. Both of those indications you have to be careful with, because the implant is short and you want to really manage the bone as optimal as possible. So it's a bit more of an implant for the experienced clinician. On the right side, you notice here this is a tapered implant, and it has the abutment and the post attached. This is a Noble Direct. It's a one-piece implant. Again, it's a bit more of a specific implant, and I definitely would like to recommend first to develop some more experience with two-stage system like here, the Replace Select Tapered, which makes it a little bit easier. Now the drill kits. You can see here the drill kits which I use here. This is the tapered replace system. And pretty much today, all the systems which are out there utilize something which is similar. For me, of course, the most important is that the drills are really sharp and precise, and that the drill unit which is being utilized with them has really an optimal way of using precision when we prepare the osteotomy. So I know from like the kits I have right now that they're delivering this kind of setting. I add one drill to it, and that is this drill here, what I call the precision drill. This is a drill which is available from different companies. Noble has one, Dentatus has another one, and they're available. And what it allows me is that I can actually place a drill into the bone site, and I can exactly follow that position. so I don't lose the precision of my initial cut in the bone. And then I can follow with the standard drill set. How long can you use these drills? And it's difficult to say, because really it depends, of course, on the amount of procedures you're doing, as well as on what's the quality of the bone. So a dense bone, when you're doing a lot of edentulous arches, you're treating patients and helping them with implants in the anterior mandible. Of course, these drills will lose their precision quicker. Now, a next drill, which I like to add to my list of drills, is a dense bone drill. And a dense bone drill can mean just different drills which have a larger diameter. So a diameter which take away some more bone, in particular in these kind of cases. So I like to add that to my drill set because it gives me more flexibility when I treat the bone. Specifically, when you're using parallel bone walls or parallel walled implants, this is very useful. Then to look at the screw taps. Some of the older systems don't have the full screw taps. So I would recommend you to look at the screw taps you have and to develop a feeling of that these screw taps are really the full tap, so they have the full body of the implant. And I use the full screw tap sometimes up to 100% of the length of the implant, and sometimes only 50%. So it all depends how I use the screw tap. Sometimes it's only the top part which I tap, and then the bottom part really does not get tapped at all. So it all depends on the bone quality and the bone site. The torque wrench, an important tool to feel and to measure the type of implant position. So this can be manual, but you can also measure the torque from the drill unit. So this here really is something you can look at and improve. So a torque wrench is really important to have in your kit, and also to have a maximum torque. My maximum torque I use is about 35 Newton to 40 Newton, and once I pass the 35 to 40 Newton, I will always reverse torque it and make sure that there is no pressure on the site itself. Okay, so this is towards the drill kits. Now, the next topic will be radiographs. So let's take here, we approached about half of the presentation. So let's take here a 2-minute break, cool off a little bit, because here in Los Angeles it's pretty warm. And you can maybe take some water and take a break. And if there's any questions, you can put that up in the chat room right now. And then I'll be back in 2 minutes with our next topic, which will be radiographic organization in the office. So at this moment, we're moving now into the necessities of a practice and looking at what kind of radiographs would a surgical clinician need to support his or her quality of care. So here it is. The first two radiographic piece of information are a periapical radiograph, and that's obvious. The periapical radiograph shown here, and of course, if possible, also the full mouth x-ray. And the periapical radiograph, of course, very good because it gives you all that localized information which is needed when you place an implant. So it can be making sure you can see the anatomy close by, adjacent roots, potentially some kind of foci of infection, and areas where like you really feel that you need like a very small area to evaluate. The second x-ray, which is very helpful, of course, is the Panorex. And this is a standard radiograph which is necessary, so you can look at the overall jaw bones. You can see what the anatomy is of the nerves. You can see the sinus floor. You can see any kind of course, dental problems. You can see any kind of jawbone pathology. You can see condyle problems. So it gives you an overall view of this area, which is very, very generic. Okay, I'm just looking here at one question, and the question is posed here. I'm just going to read it. Does the full screw tab come in the guided surgery kit, replace select tapered kit? Coming from Steve Rhodes. Steve, good question. I actually don't know if I can answer you this here. I have both of the kits, so I have the guided surgery kit for the Brannemark as well as for the replace, but I really don't know at this moment if I can answer you very exactly. So I would recommend you to go to obviously one of the company reps and then ask this question or get it from one of the specialists. This is all new. Remember, the whole guided surgery kit, of course, is relatively new from patient care, so a lot of this is still being developed. So sorry I can't answer you more precisely. Okay, we're continuing with the radiographs, and these two I would consider to be minimum standard. Now we're adding a second standard to it, and that is the three-dimensional CT scan. And I personally believe that with the arrival just a few years ago with cone technology, the needs as well as the possibilities of diagnosing cases with a cone technology CT scan are enormous. So we're more and more today bringing CT scan diagnosis into our surgical planning stages. And obviously you can see here that what's happening is this patient had already implants in the maxilla, but she was now indicated for implants in the lower jaw. And of course I want to see this, so I have a periapical, as you can see. I have also an panorex, but I want to see where is the infravillar nerve. And of course I can trace it. I can look at it. Where is it in the posterior mandible? Of course I can go and find the mental foramen, but it's always sometimes of a guessing game. So we want to be more precise in these particular cases. So this is where a CT scan really can give us just a very simple fashion already, like diagnostics. And you can either just look at the cross-sectional views and then analyze it from there, or you can have a radiologist even make these markers in there. So for me, the arrival of cone technology makes it possible really to move into the game of better diagnosis. Now, three companies are available at this time. One is the Newtome. That's a CAT scan machine which I'm very familiar with. Very, very good results. Then there's the iCat, and then there's the Morita. Newtome is Italian manufacturer, iCat US manufacturer, Morita Japanese. The most precise is probably the Morita, but it's the newest one on the market, and it also has a much smaller focus line, so you can't take a full jaw really. You have to take multiple scans. The iCat and the Newtome will take a fully edentulous jaw and make it easy to really work on. So the next advantage really now of this type of work is the precise three-dimensional diagnostics and the low radiation. This makes it, of course, very, very good for patient care, and some of the 3D cone CT scans have a radiation which is maybe just 3 to 5 times the level of a scan, of a panorex. So in the near future, you can imagine it will even be lower because we're not looking really here for pathology. We're only looking here at diagnostics. And the best part of it all is that there is software, commercial software systems available. One which has been here first in the market was the Simplan system. A more recent arrival is the Noble Guide system. And these make it possible for us today to really diagnose in the office the implant placement, and then transfer this to the surgical field, potentially a template, like the Noble Guide system really delivers. So now, of course, the question is, well, who's going to do all this? I'm so busy. I have a busy practice, I don't have the time. I understand. That is very normal, that in a busy practice, the key clinician will not be able to do all this. But you have your dental assistant with maybe some advanced training, which you can then put in charge of this, or you can have an associate who can have some extra job descriptions in there and have some extra fun with it. And you then just come in and check it when it's all done. So these kind of software programs make it very feasible to be done today, and pretty much what they do is they make the life of the clinician better. There's less surprises. They make the result for the patient better, and also it drives you to really pre-diagnose everything before you go into surgery. So I like these kind of cases very much, and I think it's a good way to start implementing this in your office. And obviously patients like it too, because they know that what you're doing is you're spending time to diagnose their case better. And as you can see here, what it also will be able to help you with is that actually some of these minimally invasive procedures, which today don't include anymore making incisions as a procedure, as we call it today, the punch implant surgery. Well, the punch implant surgery, what it can do, it can very nicely actually allow you to now diagnose the implant position in the field, and you can also have a look at the overall cross section, and this gives you a very nice view, as you can see, where the implant will be placed. So diagnosing it with a scan and using these kind of Simplant or Noble Guide simulations help you to position an implant better. Secondly, of course, now you go sometimes into like more advanced procedures. Like for example, the left periapical shows, of course, that this patient needs a sinus lift procedure. And you want to know maybe, can I do an osteotome technique, or do I have to do a lateral window technique? So this gives you a good way of looking at it. So a scan can help you. On the right side, in a particular case like this, again, the bone looks pretty good, the height looks pretty good, but you might just want to see the cross section. So again, it's an additional effect. In the posterior mandible, well, here definitely, of course, once you go and you go on top of the second premolar, or you come to a crestal area which is very thin, you want to see this here cross-sectionally. And then when you talk about the lingual fossa, of course this here makes it then also a need for extra diagnosis. So a scan in the posterior mandible helps you to diagnose the infraorbital nerve. It helps you to diagnose the thickness of the ridge, and it helps you to diagnose the sublingual concavity, which is below the mylohyoid ridge, so or the fossa. So, and then when you place implants into this area, you have less now danger to hit the nerve, to get into the concavity, and to place it in the optimal ridge. So I think it's an obvious for the posterior mandible. How about the anterior maxilla? Well, the anterior maxilla, I think the most important reason to use three-dimensional scans is really anatomy. How thick is the plate? How large is the nasopalatine foramen and incisive canal? Does it potentially interfere with implant placement? And how far is the nasal floor? So you can see that here. So these kind of particular cases obviously can benefit from advanced diagnostic techniques because they will help you to position it better. What about edentulous arches? A little bit different maxilla versus mandible. When I look at the mandible, here in the anterior mandible we have very few anatomical limitations except for the mental foramen. The bone is good. We can live with short implants. So very often the edentulous mandible gives me a potential to, place implants without really making a problem in these particular cases. So the edentulous mandible, there's nothing against using a CT scan, but I usually don't do this on a regular basis. This, of course, in contrast to this is the placement of 5 implants in the mandible, and obviously the only major anatomical limitation here would be the mental foramen. This is more difficult, as you can see. This is the edentulous maxilla, and I would say if you want to get into surprises, maxillas are always full of surprises. You think there's a lot of bone, you end up after raising a flap that there is a potential for deficiencies and not optimal implant positions. So here you have the chances of rolling. So I like to keep my life as in the surgical field, of course, controlled. So I think a CT scan really helps you very well in these areas. Okay, now we're ready to move to the next topic, and that is medications. Medications. Several groups, as you can see here, and the main 4 groups are noted here. Step 1. Implants is an elective treatment. So that means for me that when I look at patients, that everything is pre-controlled. So infection is controlled, emergency treatment is controlled, and diagnostics is controlled. Then we go to surgical implant practice. Then the first thing I would like to control also is any potential periodontal bacteria. So no bleeding on probing, no pockets available, and if any pockets are there, they should be, as we call them, the dry pockets, controlled pockets. Then I go with the patient into a pre-cleaning stage. So about a week prior to the procedure, we'll have the patient come in for cleaning, and then from that moment on, the patient is kept on chlorhexidine to reduce the bacterial count. Then the patient comes in about an hour prior to the procedure, and then in that hour prior to procedure, they'll take antibiotics, and then at that time, they'll also take analgesics. Now, my antibiotics of choice would be a broad spectrum, so something like amoxicillin. If they're allergic, we'll give them clindamycin. Analgesic will be ibuprofen. And then there's an additional effect which we can give the patient, and that is oral sedation. And the oral sedation is, of course, an oral sedation, of course, is an issue which you can decide upon on the patient. And you can also do intravenous sedation. For me, I like oral sedation. Patients are very relaxed with this. And the drug of choice here in my office is triazolam or Halcyon, and we give half 0.5 milligrams in these kind of cases. So this here gives you a way to control the patient. Steroids, often discussed. I personally don't like to give so much steroids because it reduces the regenerative capacity of the soft tissue cells. So it's not something I really give regularly. Oral rinses continue till the sutures are out, and then the patient basically maintains health. So I can go now back to a question here from Steve Rhodes again. When using guided surgery, 5 fixtures on mandible for hybrid, would you be concerned with the lack of attached mucosa on the mandible you showed? Okay, that's a good question. It really comes down to the periodontal aspects of treatment of implant placement. When we look at implant survival over long term, and we're looking at mandibular arches, as well as maxillary arches. There's a lot of information, actually goes back 20 years now, that you can accept mucosa around implants. So if I would ask you the question, what's the minimum amount of keratinized mucosa around an implant, the answer would be really 0 in a case of an edentulous mandible or edentulous maxilla with a hybrid prosthesis. So the question is, no, I'm not so concerned with it. Would I prefer to have keratinized? Yes. Easier for the patient to clean, easier to maintain. But it's not necessary. Okay, hopefully this will answer your question. We move to instruments. Now, instruments is an organizational matter in the office, and obviously everybody has instruments. But having looked at many different offices and colleagues, and having done many hands-on workshops where colleagues bring in instruments, there's a lot still to be wished for from a standpoint of an instrument list. So here I've put out like a few instruments which I consider to be important in these particular cases. So first of all, scalpel holders. I like the round scalpel holders, something which really makes it easy for you to handle in your hands. And you can see them here in the instruments right here in this particular site. So this will make it easy for you to move it in your hand and also position it. What blades? I like to use a 15, a 15C, and a 12D. Next, the pickup plier. The one I like is the Khoury one called TP5090. It's a long plier, so about 15 centimeters. You can get easy into the back of the mouth. And I like to work always with 2 hands when I make an incision, when I elevate, when I suture. So the plier is a very useful tool for me. The next instrument I like to use is a sharp elevator. And I've designed this instrument for Khoury called the Joe 1, Joe 2, or Joe 3. And it also has a back action to it. And the back action makes it easy to either scrape the bone or to go into a concavity and very nicely control the site itself. Here it is. This is the sharp elevator on one side, and here's the back action on the other side. Just a nice simple instrument, but I think something which will be really user-friendly for you. Right to the left of it is another instrument which I then use, which is a very useful instrument here used in the US, the Pritchett elevator, with a round dull side, and as you can see here on the front side, an diagnostic or like wax-up spatula which you can use for retraction. Next instrument which I like to use is then the needle holder, and this is a round, long Castroviejo. Round, long Castroviejo. Very useful from a standpoint of suturing, and it's a pen holder, so it's very, very precise. 2 instruments which are noted here. One is the periotome. Many of us will do extractions in their offices. So the periotome I use is the one which Noble Biocare produces, but there are several ones in the market. Very good. I use that with a mallet, and I will move my periotome quite into the periodontal ligament space to be able to luxate the root out of its socket. Then I use a surgical spoon. It's called a Lucas spoon curette, just to be able to very effectively clean the sockets and also very effectively clean any bony defects which soft tissue or granulation tissue in there. And the last instrument which I would recommend you, because we always need some bone in areas, is an effective bone wrenger. And this is the Bayer bone wrenger noted in the Khoury instruments. Now for those of you who want to look at this list, and this is only a basic list I gave you, I have a much more extensive list I use in my kits. I recommend you to go to the guide homepage, And then on there you'll find materials. You'll find a link to Khoury. And then in the Khoury link, you'll find my full instrument set. So that's where you can use any of those which you feel are useful for your practice. Sutures. I use very few sutures in my office. Very few brands, I should say. I do use sutures all the time. And I keep it like relatively simple in its concept, depending a little bit on what I do. When I place implants, so I'm dealing with bone, implants, and sometimes bone grafts, I prefer to use non-resorbable monofilament materials. And there's really two materials in the market. One is Gore, CV5, another one is Nylon 6.0. Those are my two sizes. When I start to work more in soft tissue, I work with the same type of non-resorbable materials, but I can go to resorbable. And when I use the resorbable materials, I use chromic gut, 5.0, 6.0 size, and I use Vicryl 5.0. All of these sutures are being utilized with a cutting needle. A cutting needle, so I can really move the sutures easily through the soft tissue. Now the drill units. The drill units are something of course, it depends on what system you use. And I have used for the longest time the drill units which are available through Novabic, and having used that for like 15 years or so, I have arranged quite a bit of drill units. So if you're ever interested to see all the drill units they have brought out, I have them. What do you want out of a drill unit? I want a very controllable machine, which again has few functions, but controlled. So I want low speed with high torque, and I want high speed with high torque. I want a foot pedal, which is immediate, so it gives me control, and it gives me a reverse, for example, for the tap and for the implant, and it gives me a water control. So I can pretty much do everything with my foot without really having to ask an assistant to do this or interact with this. The speeds, which I use for high speed, are somewhere around 800 to 1200 RPM, and this works really well. This is the newest kit, or the drill unit. Efficient, does very well. At the same time, I'm not particularly fond of this drill unit with its foot pedal, because the foot pedal has a delay. So you step on it, and it will take a second or so before it starts to run the drill. So this is a safety feature they have put in, but I think that from a precision standpoint actually it takes away some precision for me. So, but I have adapted myself now to using this, and it's fine. The next, of course, is then the use of the torque. And here I've just put you in this particular area the high torque I like to use. Of course, when you use a screw tap, there's no worry because you use at the maximum torque, because you will reverse it, and you're using rinsing with water. But once I start to place the implant, I reduce the torque to 20 Newton. And then once the implant gets seated and stops, I get a maximum, we go to 30 Newton. Then I reverse again, and I go to 40 Newton, and that's my maximum. And I always will allow myself to have some kind of control with this torque, and this is really for me a wonderful way of controlling very much the way of evaluating these kind of cases. So this gives me a nice way of controlling this torque. Now, aseptic technique. Now let's have a look at this a proud member of the staff, which you can see here, and a couple of things which are important. A, surgical gowns, which are sterile, sterile gloves, head cover, face mask, eye protection, and shoe cover. So, and that's what you can see here. Now, let's divide them into two different ways. One is the implant placement, and second one is the uncovering procedure. For implant placement, I work in my clinic as a surgeon, so I have one sterile gown, and I'm dressed up, and I have two surgical assistants, one chair side, and one delivering me instruments and delivering me the implants and the handpiece. Then, of course, we have a sterile package. This sterile package will allow us to keep everything nice and clean and sterile. We go through the washing of the hands. We then have the sterile gowns and the gloves. We have the patient drape, and we have the sterile counter drapes. So all this actually during implant placement, I keep pretty sterile, as you'll see in a moment. Then the uncovering procedure. The uncovering procedure, it's one surgical person, a surgeon, and one assistant. It's usually enough. Both of those can be clean. I don't always go here into like the sterile gowns because this is most often just a soft tissue procedure like perio. But I'll use a sterile patient drape, and I'll use sterile counter drapes. And otherwise it's all clean. So now let me move into the next video.
Now that all instruments have been placed and made ready for surgery, the surgeon is ready to scrub in. The surgeon will also wear shoe and hair covers, place face masks and safety glasses prior to hand washing. The hospital scrub kit includes a nail pick, which should be used to clean under each nail prior to scrubbing. The scrubbing should be started around the fingertips. Then, moving upward to the palm and the back of your fingers. Then, back of the hands, wrists, then forearms. Rinse starting from the fingertips and continuing to the elbow. Do not rub your hands together and avoid touching any non-sterile areas after rinsing, including the faucet to shut off the water. After rinsing, use sterile absorbent towels to dry the hands and forearms. Be sure to start with the fingertips and finish at the elbow.
So now you've seen the hand washing, and this is like a routine which I do in the office. The next we're going to look at the sterile packs. And this is something which you can develop yourself in your practice. And this here really is a very good system because the different companies offer this here. Novarke has a very complete set, and some of you might reuse. Salvan has a very good set, and we have this one, which is a customizable set. So basically, you can call in a representative of the company, and then you can say, okay, I have two sterile persons in the surgery, so I just need 2 gowns. I need this many drapes and these many towels, etc. But here's what's necessary. I think you need to have sterile gowns, obviously for yourself and for your assistants. You need drapes for the patient and for your countertops and potentially any mobile tapes. You need towels to as well dry your hands after the hand washing, as well as towels to place on the chest of the patient. You need cups for water and for chlorhexidine. You need gauze for doing your procedure to clean. You need suction tips and hoses. So those are some of those cases which you need to really promote this here. Question here from Dave Miller. What supply company? Salvin has this, but this is the company which we use at UCLA, which is called PSC. And if you can't find it, you can just email us or email me, and then I'll get you the home page and the link to this here. It's something like Professional Systems or something like that. But it's nice because you can really customize these packs and make it very easy for your staff and for yourself. Okay, so now let's look at the gowning, because this is also something which often is difficult for staff because it's new.
Once the assistant has scrubbed in, this assistant is now ready to put on the sterile gown. The sterile gowns are packed so the inside of the gown is facing out. Only grab the inside of the gown. Do not touch the outside of the gown, as we want the surface to remain sterile. Notice how the assistant did not bring his hands all the way out of the sleeves. The non-sterile assistant can help tie the inside of the gown and clip the two back ties to the sides of the gown behind the neck. The outside of the gown will be tied with sterile gloves only. The sterile assistant is ready to pick up sterile gloves using the sleeves as covers for the hands. This will prevent the hands from contaminating the sterile field. Notice the assistant is putting on the gloves without taking his hand out of the sleeve until the glove is in position. Make sure the glove is rolled up and is over the sleeve of the sterile gown. The last tie for the gown of the sterile assistant is located in front of the gown. The sterile assistant will pick up the paper tab that holds the ties together in the front of the sterile gown. By grabbing the paper tab, this will release the ties. Now the sterile assistant can give the non-sterile assistant this tab. As the non-sterile assistant holds this paper tab, the sterile assistant then turns 360 degrees until the tie is wrapped around his waist. Then the sterile assistant pulls off the other end from the tab and ties the ties together. This process can be easily remembered as grab, turn, pull.
So this showcased you the technique of gowning of the assistant, gowning of the surgeon, as well as putting the sterile gloves on, and then the grab, pull, and turn technique. Now, of course, here you can see all the sterile environment, and here you can just see a regular countertop. We clean the room, a regular dental room. This is the room which I use, is shared with the aesthetic department. So it's a medium-sized room which is clean of anything, just countertops. And we clean it off, and then we move in with our sterile pack and cover it. And here you can see, just as here are the instruments, the Khoury instruments. Here's some topical anesthetic. Here's the gauze, which comes out of the packs, an osteostome kit. Here's a cup with some chlorhexidine with anesthesia. Here's a larger cup with water, sterile water. Here's some smaller cups for bone. Here's a bioos, irrigation syringe, and then here the drill unit. So you can pretty much see everything in place which you need for the procedure and easy to work with. And all this is managed by the sterile second assistant, because the first assistant is working with the patient. And all this is considered a sterile environment. Now, when we place the patient into these kind of conditions, draping, let's have a look how we really drape the patient.
Place the first towel folded lengthwise on the patient's forehead, covering the eyes for protection. Place the second and third towels to the right and left of the patient's face, converging just under the chin. Place the split sheet right under the chin, making sure the arrow on the back of the cover points downward. Unfold the sheet downward by being careful not to touch any unsterile areas on the patient. Continue unfolding the top part of the sheet, making sure the split is right under the patient's chin. Remove the paper tabs . have the patient open their mouth to make sure the drape is not too high on the patient's neck. If the drape is too high, the drape can prevent the patient from properly opening their mouth during surgery. Use the sticky areas to position the drape at the edge of the towel around the patient's face. The sterile split drape has 2 tabs at the waistline, each with 2 holes. These tabs are used to attach the suction tubing, which prevents the suction tubing from rolling onto the floor. Place the suction tube, the irrigation tube, and the bone trap tube, if needed, through the holes.
This, I think, showed you very nicely how here my associate just moved in all this here in position, and then together with the assistant cleaned and made everything nice and sterile. Now let's look here at this picture. This gives you a normal dental room. This was just now done under IV sedation. You can see in the background the anesthesiologist. You see the drape which is just being placed on the patient, the towel, here an opening. So this here is obviously not closing the eyes of the patient, so you might want to choose to use some kind of eye protection for the patient. But just remember then also the sterility of these type of procedures. Here are the surgeons. This is Dr. Moldovan, and you can see her here in the sterile gown, sterile gloves, the face mask, the head cover, and the normal routine sterile procedure. And here the second surgical sterile assistant who is working right here just to prepare everything for the procedure itself. And the only person you don't see is the sterile chairside assistant who is also sitting here with a sterile gown. So this is a regular dental chair. This is the room which I use most often at UCLA. Now here you see me working in a more, I would say, hospital-based setting. And this was done at the University of Hong Kong. And it's a slightly larger room, and I don't think really it's necessary to work in these conditions. Of course, it's nice if you have the luxury to have larger rooms, more controlled, but it's really not necessary. A couple of points of interest here in this picture, which you might want to look at, is the sterile setup is pretty much the same. I'm pretty much the same here with all the covers, etc. But here the viewer. In the dental office, you would like to have a viewer which obviously makes it good for you to display the CT scans, panorexes, and periapical, potentially full mouth x-rays. So something needs to be purchased which really displays this nicely from a standpoint of a radiographic display. Secondly, you see here a mobile cart, which is also useful, covered with a sterile cover for all the instruments. And then thirdly here you can see an operating light, which is very useful, and they're available in all different dimensions. So you don't have to have these very advanced operating lights like in a hospital OR setting. You can have these smaller satellite operating lights. And the nice thing is they give a very focused light, very strong light, which obviously is necessary when you do a procedure. And they have this little handling knob here which can be sterilized so you don't contaminate it when the surgeon or the assistant redirects the light. So this is an interesting way of looking. Now, continuing to look at operating lights, this is a system which is fairly simple to do. Most dental companies will be able to help you with this when they install this in your office. Instead of having one operating light, just have 2. And it will always make it better for you to have more light. So this can be done on the same track usually and very user-friendly. So in one of the rooms I have here in Los Angeles, I have this set up with 2 lights, and it functions really well. Of course, you can also always go into a small operating light, which can be purchased from one of the companies. Then another tool which I like to use when you're doing implant procedures surgically is a laser. This, of course, is an additional tool. You don't need this to perform implants, but I use the erbium chromium YAG laser produced by BioLase for, to move in with these procedures with minimal invasive soft tissue procedures. It's relatively pain-free. Many of these cases we don't give local anesthetic, so it really helps us to do these procedures. So for patient care, this can really be done very well. So look at this here, just kind of as an option, and when you're moving into the practice of implant surgery, this can help you also to be minimally invasive. Microscopes. I have a microscope in my office, but quite honestly, I don't use it very much. I'll use most often my 2 or 3x magnification glasses, and if I use a microscope, it's very seldom, really to look more at an internal aspect of an implant or some deficiency or defect, which is very, very delicate to note, and so it gives me more clear vision. But you can, of course, if you have the option and if you like to, install a microscope to use with your surgical implant placement, and it might help you. Okay, I'm ready to finish, and just to finish, I think it's always fair, most of the viewers are going to be clinicians, so let's finish up with one nice case to show how to use everything we do. So pretty much I'm presenting you here with a patient who has 2 failing center incisors which need to be extracted, and 2 immediate implants will be placed. So behind the scenes, I took a Panorex, I took a PA. In this particular case, I did not take a scan. We made study models, had diagnostic wax up, had a surgical guide stent. Patient was on antibiotics, had a rinse, and a cleaning was done. The patient now went into the room. It was a surgical, sterile environment. 2 assistants were there, and I've chosen to use a tapered implant because it's an extraction socket. I'm using a round scalpel handle with a 15C on the top right picture. I'm using a periotome on the lower left, extracting these roots carefully. Here then I place the implants, again, very carefully, utilizing the sockets and utilizing the palatal bone. Using another instrument, which I like to use, a probe, a UNC15 probe, to really measure exactly. Then, this is an immediate function concept, so without raising a flap, this particular case received temporary prosthesis, crowns on the implants, no function, no lateral forces, no contacts. Leave this in place for about 6 months, then we deliver the final crowns, which you see here. So this is a nice, clean clinical case which kind of supports, and everything which we have done and discussed in this particular presentation was done for this case. So, everything we do, we want to deliver success. So hopefully this presentation gave you, with the use of the different concepts, with the use of the videos, a nice way of looking at these particular cases. And what you can see here is really that we have an area which really has an option to clean this area, and you can also move into this concept of surgery. It's not too difficult. It's just like changing the concepts in your office a little bit, talking to the staff, probably be good to show staff parts of these videos, and this can really help you. Now I move to you, and any questions you have, you're welcome to ask. With the taper drills, do you use the internal irrigation? Okay, that's a good question, David. Personally, no, because I've been used to the Brandemark system for many years, so I'm very used to moving with the drill and having the external irrigation. But if I have drills which have the internal irrigation, then I obviously attach it, so I just have an additional way. But it's not that I'm going out to purchase these because I think it's better. No. I use a system where I have a very clear control of irrigation, and I think that there's no advantage of internal versus external irrigation. That's fine. It's just whatever is your preference and whatever you think you can control better. So, but for me personally, external is fine. What has been so far your experience with the groovy implants? Okay, good question. For those of you who don't know what the Groovy implant is, it's basically a new implant, about a year now in production from Nova Biocare, where the tyenite has been moved up to the top of the neck and horizontal microgrooves have been added to the surface. So first of all, experience is good. No problems. Then secondly, conceptually. Conceptually, I definitely prefer implants with the tyenite surface or with a rough surface all the way to the top of the neck. And as some of these implants do not have grooves or threads going all the way to the top, which are mechanical stabilizations for bone, I like microgrooves. I mean, these have been around in research for the last probably 20 years. And they guide cells and they stop cells from moving apically. So I don't have very long experience with this because it's been on the market very recent. But the experience I have are good. I choose the implant, so I purchase the implant, and conceptually I like the idea. Are they placed to the same level as Replace Select crest of bone? Okay, first of all the evidence in the literature today points us to placing the implant superior to the crest. So I don't place implants, neither Brannemark or Replace, flush with bone anymore. So they'll be positioned most likely about 0.5 millimeter to maybe 1 millimeter above bone, usually about 0.5 millimeter. And this is for Replace Classic, so to speak, as well as Replace Groovy. And depending on the emergence profile I need, I can even go higher. Because with the Groovy, you have the tyenite actually stabilizing the connective tissue, and the microgrooves also stabilizing the connective tissue fibroblastic cells. So short answer, no, I don't place it at the crest of bone. I place it slightly superior to the bone, about 0.5 millimeter to 1 millimeter. Okay, bye-bye everybody. Bye-bye.